Okay, can everybody see my screen now?
Yes, now we can.
Okay, perfect. So let me start over again. Thank you for being with us here today. My name is Troy Graber. We're going to talk about the importance of longer duration heart monitors and why you really need to get the longer duration to get the diagnostic burden required for a good diagnosis. My name's Troy Graber. I'm a registered respiratory therapist. I have managed cardiopulmonary departments for the majority of my career. The first cardiopulmonary department that I managed was over 15 years ago. So I have really gotten to see the changes in cardiac monitors and how much they've improved over the years. I'm going to talk about the diagnostic advantage of long-term monitoring and why it's important to get beyond that 1 day to 2 day monitor in order to get a true diagnostic burden to be able to give a good diagnosis for your patients. I want to start out just briefly on how we got here. The history of the electrocardiogram. 1887, Dr. Augustus Waller, he was a British physiologist, recorded the first human electrocardiogram using a capillary electrometer. This marks the first time the heart's electrical activity was ever detected or recorded. Waller often demonstrated this technique using his dog Jimmy, who's pictured here with him. He did this by taking Jimmy's paws and sticking them into a bucket of saline in order to record that electrical activity. Then Dr. William Einthoven took this a step further. Einthoven was a Dutch physiologist who was inspired by Waller's work and developed the highly sensitive string galvanometer. This device utilized a thin silver-coated quartz string suspended in a powerful magnetic field. He then connected electrodes to the patient's hands and feet and put them in buckets of saline. This is where we get Einthoven's triangle from. Einthoven's machine, although groundbreaking at the time, weighed 600 pounds and took 5 people to operate it. So that's about as far from portable as you can get. It also required a great deal of manpower, so it was impossible to do serial EKGs on patients. It just wasn't even in the works at that time. And even if we could, they were just squiggly lines on a graph. Electrocardiograms weren't really clinically useful at that point. Now in 1903, this is when Einthoven labeled the electrical deflections of the heart cycle with the letters that we're used to today, the P, Q, R, S, and T. At that point, it became a diagnostic tool. In 1906, he went one step further and connected his laboratory to the academic hospital in Leiden via telephone cable to record patients' electrocardiograms. This established the ECG as a viable clinical diagnostic tool. In 1924, Einthoven was finally recognized for his genius. He won the Nobel Prize in Physiology and Medicine that year for his discovery of the mechanism of the electrocardiogram. He died shortly after that in 1927. So now let's get into modern Holter monitors. In 1947, Norman Jeff Holter started the Holter Research Foundation. Initially, his focus was on the study of human electrical activity. In 51, he shifted that focus to the heart's electrical activity. And then in 57, he came out with the first portable ambulatory ECG system. I say portable in that it was not very portable. It was backpack based and weighed 75 pounds. But it was that first device that allowed the continuous monitoring of the heart rhythms outside of a hospital setting. In 1962, the first commercial version became available, which you see here in the picture. It utilized a reel-to-reel recorder and a little, basically like a purse the patient had to wear to carry that device. It was a huge breakthrough at the time, but not very portable compared to what we have today. So now let's look at where we're at now. Now we have transitioned to the wireless patch-based devices. This is the device that we use. It's from Boston Scientific, and it's called the Bodyguard Mini. All these patch devices utilize a patch or an adhesive strip to connect it to the patient's chest. These are much more comfortable for your patients to wear. They can actually swim with these on, they can take a shower, and you can get that continuous tracking of cardiac rhythms. The patches are discreet, they're comfortable, and allow people to continue the activities of their daily life with minimal interruption. Patients are much more willing to wear these patches for longer durations than they were your traditional Holter. This is an example of a traditional Holter monitor like we used here at DCH up until about 7 years ago. There are 5 leads that have to be placed across the chest, and the patient has to manage this little pack as well. We've gotten that down to a device this size that you wear on your chest. Much easier. There's no wires, nothing to manage. And actually, I've been wearing one all morning. Let me kind of show you what it looks like on a patient. So very easy to put on, very easy to wear. I forgot I've been wearing this actually. So they've come quite a long way in a short period of time. With these patch monitors, you do still have options if a patient can't, for some reason, cannot wear a patch. I've found that about 99% of patients do great with a patch. If for some reason body habitus dictates that we cannot put it in the traditional orientation, we can turn it horizontally. And then we have other options too, such as these are hydrocolloid sensitive skin patches that can be worn for people who have very serious allergies to adhesives. We also have a one-wire lead that you can see here in the picture. This is a great option for people that have severe skin sensitivity. Even the hydrocolloid is too much for them to take. That opens them up to use any electrode on the market. We have a 2-wire option for like fresh open heart patients where you cannot put the strip across that recent scar. We can do a 2-lead option. And then there's also a 4-wire option if you need to get multiple channels. With the 4-wire option, you can get 3-channel view of the heart's electrical activity. So although the patch is the preferred method for the patient, there are other options if body habitus or other conditions dictate the need for it. I'll be honest with you, we do not even stock the leads here at DCH. We have such good luck with the strips that we haven't had the need up to this point. Little overview on long-term Holter monitoring. So AFib, that is the most common serious arrhythmia. Over 6 million people in the US have AFib, and we expect that to double by 2030 to 12 million. Long-term Holter is an effective diagnostic alternative to your short-term Holters. Your 24 and 48-hour monitors are not going to capture all the patient's symptoms and can often require repeat monitoring. That repeat monitoring gets costly as well as it's just burdensome operationally. Your 24 and 48 Holters are no longer the gold standard they used to be. Longer duration of monitoring will detect additional arrhythmias, and patient preference definitely makes this a better option. Wearable patch monitors can record at least 8 days of ECG data, have a higher compliance rate when compared to 24-hour traditional monitors. So let's really think about that. Your patient is more likely to complete the duration with one of these patches for 8 days than they are to complete the duration for 1 day wearing a 5-lead traditional Holter. It's all about compliance, and we know that convenience drives compliance. If we can make it convenient for our patients, they're more likely to do what we need them to do. Talk a little bit about clinical and financial burden. 7 out of 10 of your patients are going to go undiagnosed with a 24-hour Holter monitor. That's huge, 7 out of 10. The financial burden, that's about $4.5 billion spent for undiagnosed patients over a 2-year period. And that's billion with a B. Medicare patients, that's our money. We're all paying for that when we pay taxes. The Holter was the most repeated test during a 2-year follow-up, and it was often repeated within the first 3 months of that initial test. Let's think about that. Why would we be repeating a test within 3 months? It's because we feel very confident there is an underlying arrhythmia there, but we didn't capture it with that first 24-hour Holter. So again, longer duration, more diagnostic burden, you can make better decisions for your patients. Talk a little bit about the benefits of a patch. Again, AFib is a heavy burden to our healthcare system. $6.7 billion per year for the management of AFib. $3 billion of that is just on hospitalizations. So how can a patch help? Well, it can increase your clinical accuracy so you can make better treatment decisions and have better patient experiences. In my opinion, this is the most important slide of the entire presentation, so please wake up and pay attention here. We're talking about diagnostic burden, diagnostic yield. You can go from 55% with a 24-hour monitor up to 100% over a 14-day monitor. That is huge, especially when you consider at 2 days, you only come up to a 71%, and at 3, you're only at 80%. We really need to be ordering a minimum of 3-day monitors, and ideally, let's go for 8 to 14. When you get to 8 days, you're at 97% diagnostic yield. That's huge. What a difference we can make for our patients by just making that duration a little bit longer to catch those additional arrhythmias that we're currently missing. Something else to keep in mind when you think about this, we often consider cost. You know, how much is this going to cost our patient, and are they going to be able to afford it? Well, the nice thing to keep in mind about these monitors, it is a very minimal difference in cost from going from a 3 to 7 day to an 8 to 14. It's around $45 for that hookup cost difference. Also, you need to consider that Boston Scientific, our company who does the interrogation and generates the reports, they charge the same fee, whether it's a 3-day monitor or a 14-day monitor. So you can take that patient from an 80% diagnostic yield all the way up to 100% for just less than $50 more. That might be the most effective, cost-effective deal out there in diagnostics right now. I can't think of any other test where you can increase the diagnostic burden that much for so little cost. So we should really be taking advantage of that whenever possible. One of the really nice things about the monitor we use is that it's submersible. This is very important, especially when you consider your pediatric population. We can treat a patient with this monitor down to 22 pounds. Those of you who have children know how hard it is to keep a child out of the water on a hot summer day. You can swim with this monitor on. You can take a shower with this monitor on. We don't recommend that you take warm baths because soaking in the warm water will kind of loosen up the adhesive, but people can take hot showers. We just recommend you don't allow the water to run directly onto the patch for an extended period of time. Even when people swim, when they take showers, we don't have issues with these patches coming off. Another nice thing about this equipment, you can get up to 16 days of battery life on this mini without recharging it. So if you order a 14-day monitor, your patient will probably never have to put this on a charger. When we move over into mobile cardiac telemetry, it goes down to around 8 days because you're sending a lot of data. It's just using more of the battery, but so convenient. And what do we know about convenience? Convenience is going to drive our compliance. It doesn't matter whether we're talking about glucose monitoring, aerosolized drug delivery, or cardiac monitoring. If we can make it convenient, our patient will be compliant. Talk a little bit about the comparison of your 14-day patch versus your 24-hour Holter. This was a study done with 102 physicians surveyed. We took 146 of their patients. We put them on a traditional 24-hour Holter as well as a patch monitor, wore them congruently. What we found is that our diagnosis rate for the 14-day patch monitors was around 90%. That 24-hour monitor dropped down to 64%. So that's a huge disparity. Then when we look at patient comfort with their satisfaction, an even greater disparity. A 14-day patch, when surveyed after the test, the patient, 93.7% of those patients said that it was a comfortable patch to wear. It didn't bother them. When they looked at the 24-hour monitor, only 51% of those patients said that it was a comfortable experience to wear it. And again, what do we know about convenience? It's going to drive compliance. So if we can make it comfortable, they're more likely to wear it for the full duration and get the most diagnostic yield for us to evaluate. Talk to you a little bit here on this slide about battery life. So again, you can get up to 16 days with your Bodyguard Mini if it is used as a long-term Holter. If we then convert that to a mobile cardiac telemetry device, it's going to drop to about 7 to 8 days. And we'll talk a little bit here about the differences between those on this next slide. So these are kind of your three options: your Holter, your cardiac event monitor, or your mobile cardiac telemetry. Holters, you've got the two styles. You've got your original 24 to 48 hours, which are often going to be your 5 leads with the box, or you have your patch device. Your patch devices are going to be utilized for longer periods of time, up to 14 days. The thing to remember about a Holter monitor, a standard or a long-term, there will be no data until this device is returned, it's downloaded, interrogated, and a report is generated. Whereas with our mobile cardiac telemetry, we're actually linking this device to a cell phone type device, which transmits real-time data to a control center, where it is then ran through algorithms, which flags anything that looks suspicious, so a live person can then evaluate it and decide if that arrhythmia is actionable, if we need to contact the provider. I think in the past, a lot of providers were ordering 24 and 48-hour Holters because they were concerned about their patient. They didn't want to wait 14 days to find out if they're having an arrhythmia. In reality, if you have a patient like that, you have great concern that they are having arrhythmias, you don't want to wait, you probably should order the mobile cardiac telemetry. Mobile cardiac telemetry can be ordered anywhere from 3 up to 30 days. But again, you will get real-time information about any arrhythmias that action needs to be taken for. Your mobile cardiac telemetry is a little more costly, but again, you're getting so much more diagnostic yield that there is a lot more value in it. Cardiac event monitoring, it's kind of in the middle. You are going to get that beat-to-beat recording. You are going to get the algorithmic surveillance, but you're not going to get quite as much diagnostic yield. The algorithms are not going to look at as many things. It's just kind of an in-between between your Holter and your MCT. Improving clinical outcomes. So if we have 2 out of 10 patients had undetected AF after 7 days, 1 out of 10 patients had an undetected AFib after 14 days. So again, most of your patients, you are going to see it within that 14-day window, but you'll have outliers still beyond 14 days. Again, where the mobile cardiac telemetry really has a role there. Let's look at the value of long-term monitoring, days to the first AF detection. As you can see, the majority of your patients within that first 5 days, you will see that AF event if they're going to have one. Now, that being said, there's still a lot of patients out here past 14 days. Some studies have shown as much as 10% of patients might not have that first AFib detection until after 14 days. So there is still a place for that longer long-term monitoring, that MCT monitoring up to 30 days. Just know that that's out there. It is an option and something that you can utilize for your patients. Patients with missed AFib episodes, so your false negatives. This is also an issue for a lot of patients. If you're looking at AFib detected in the 1 to 14 day range versus AFib detected in the 15 to 28 day range, most of those will be detected within the first 1 to 14, but you will still get undiagnosed outliers in 15 to 28 days. And this kind of shows that even better. So you've got your gray there is your AFib detected in the first 1 to 14, and then your purple is your AFib detected in 15 to 28 days. As you can see, at 4,000 patients, there were still 424 that had AFib detected after 15 days. So that's over 10% of the population. Very important that we utilize that mobile cardiac telemetry when appropriate. And thank you very much for your time this morning. That is all I have for now. You'll be able to ask questions at the end of the presentation. At this point, I'm going to turn it over to Dr. Ethan Oates, an interventional cardiologist here at DCH.
All right, thank you, Troy, and thanks everybody for your time and attention. We'll get started here on my part. So like Troy said, I am an interventional cardiologist by specialty. I do specialize primarily in complex coronary disease and high-risk revascularization, but a big portion of what I deal with is still general cardiology. And so on a daily basis, I am dealing with ordering, interpreting these heart monitors and deciding on rhythm management and things like that. So we will try and keep this quite practical. I'm going to spend the first part talking about a little more about what the evidence shows on this topic, and then kind of conclude it with how I go about ordering, interpreting monitors, and then also what to do with the findings. And hopefully that's done in a way that can give you a little insight that may help day-to-day clinical practice. This is a study that I'm going to use as kind of the framework for our evidence-based discussion here. I was lucky enough to be part of this paper back in 2019 when I was in residency. You can see the QR code is there if anyone is interested in pulling it up. But this was new AFib diagnosed by 30-day rhythm monitoring. The impetus for us putting that paper together back then was at that point and the several years prior, there was really a paucity of data in the market about this whole new term at the time of device-detected AFib, asymptomatic AFib, all these different ways of saying the same thing. I don't need to belabor the point about how prevalent AFib is or that it's associated with stroke risk, particularly in the occult AFib cryptogenic stroke population. But really what was going on is all these patients were getting more and more devices put in, pacemakers or defibrillators for things like sinus node dysfunction or cardiomyopathies. They didn't have a history of AFib at the time. Sure enough, in the years afterwards, we were finding a lot more AFib than we realized was going on. There wasn't a whole lot of data on that topic in terms of learning what we should do with these patients in terms of rhythm management and anticoagulation. So what we did is we did a retrospective observational study, and this was at a major quaternary center, UAB in Birmingham, Alabama, where I did my residency. So we took all 30-day monitors over a period of 5.5 years, came up with over 2,600 total monitors. Of those, 340 patients had known AFib going into it. We didn't exclude them from the study, but we kind of analyzed them separately because our concern was incidence of new AFib and associated characteristics of those patients. An AFib episode is only counted if it was 60 seconds or greater, so this wasn't just a few beats here or there. And then we broke down the episodes into, again, patient versus auto-triggered, manual versus device-detected, symptomatic versus asymptomatic, however you want to say it. The first thing we found is that the indication for the monitor being ordered did not really have any sort of indication about whether or not we were going to find AFib. We found a very similar breakdown, primarily palpitations being first and foremost, but syncope, dizziness, prior TIA, and then a combination of those symptoms being the next most common indication. That breakdown of monitor indication was the same amongst patients, whether or not we ended up finding the AFib. So it doesn't mean we're necessarily great at, as clinicians about preemptively diagnosing AFib. We were certainly finding it a lot more in people we weren't even necessarily expecting to find it in. Patient characteristics, overall average patient age was 60 years of all comers, but then when we diagnose AFib newly in these people, the average person there was over 68 years old, slightly more females than males. The average CHADS-2 VASC score for all new AFib patients was 3.2, with 80% having a CHADS-2 VASC score of 2 or greater. So we know that's significant because that's when we start to mandate anticoagulation for stroke risk reduction. And we can see there in the chart on the right that really the bulk of our patients were having scores of 3 or greater. We know that's significant because this is a large patient sample size. I think it's pretty representative of who we're ordering these monitors. And yes, we are ordering monitors in some younger patients with palpitations and things like that. But the bulk of who we're really expecting to find serious pathology in is our older patients. And so the fact that the average patient that we're finding AFib in, yes, they clearly warrant anticoagulation by CHADS 2 VASC score there. And as we can see, really once we get above 4, that stroke risk tends to go up in a nonlinear fashion. And yes, we do weigh the bleeding risk in these patients using that has bled criteria there. But I think something that's a little bit underappreciated both by providers and by patients is when we talk about stroke risk of AFib, some patient hears, oh, 2%, 3%, what have you. They think, well, that means there's a 98 or a 97% chance that I'm not going to have a stroke. That's sort of true, but that's annual stroke risk. So if our average patient, is 68 years old and they may have a life expectancy of another 15, 20 years, that's stroke risk per year. So I often do the math for people. I say you're 2, 3, 4, 5, whatever percent risk of annual stroke times however many more years you want to live, that equals a high risk of stroke during your lifetime. So our population here of all indications for 30-day monitoring ended up finding a 3.4% incidence of new AFib. That may not sound like a huge number, but 3.4% of all patients that we're monitoring for reasons that were not necessarily suspicious for AFib is a big deal. This wasn't the only what we considered significant diagnosis. We also looked at ventricular arrhythmias, sinus pauses, and some others, but AFib far and away was the number one most common significant diagnosis. Median time to diagnosis was just 6 days, but we were diagnosing this as early as day 1, but all the way up till day 30. So this really hammers home what Troy was talking about here, where if we look at 7 days, which may be considered longer monitoring by some of our older standards, we were only catching 55% of new AFib. Even at 14 days, only 85%. So as we can see here, the tail end of that graph on the right, those are all patients, 15% of patients that we would have been missing their need for anticoagulation and potentially rhythm management by doing just shorter monitoring. And if there's really one slide in my portion that I would want to hammer home, because I feel this was probably the biggest takeaway for me personally as being part of that paper, is realizing that patients are not good at all at detecting their own AFib. So that pie graph at the top shows 40% of all patients with new AFib had no patient-triggered events, no symptoms, otherwise would not have had any idea. Only 16% of patients were exclusively diagnosed by manually triggered events and were 100% accurate. And that leaves 44% in the middle as sort of a combination of manual detection and auto detection there. But in 46 of those patients who had both auto and manually detected events, oftentimes their patient triggers weren't associated with AFib and many times not associated with arrhythmias at all. The bottom right chart here, I think, really helps to demonstrate, as you look, as the black is the percent of auto-detected events in these patients versus the lighter gray being the manually detected. The first probably 3/4 of the patients there had well beyond half of their episodes being even detected manually. So most of their events were auto-detected only. So again, take-home point, patients are not good at detecting their own AFib. AFib burden is something we talk about in terms of duration per day. We'll talk about number of episodes separately, but duration has a lot of data behind it that we'll get to in a couple slides. But 98% of people had at least one episode lasting 6 minutes or greater. And then almost a third of people had a 6-hour or greater episode. And these are important landmarks that tie into our decision for anticoagulation. Again, pretty similar breakdown here between old and new AFib patients in terms of number of episodes. Yes, the known AFib patients did have a higher number of episodes. particularly at the very high end. But we are seeing new AFib patients still have 20, 40, 50 plus number of AFib episodes caught. And then we looked at what actually clinically came of it. Did these new diagnoses actually mean anything in terms of what decisions were made by patients and providers? About half were started on anticoagulation for the first time. Of that, predominantly DOACs were the anticoagulant of choice. We did have some warfarin. Only 12% were started on aspirin, and I think at this point the data is kind of out that aspirin is really not doing a whole lot for us in terms of reducing risk of thromboembolic events. 29% either had new initiation of rate control medication or an adjustment to a rate control medication they were already on. 21% had initiation of an antiarrhythmic drug, and then 6% went on to have ablation. 19% did not have any change to their medications or a procedure done. Now, of those, some of them were already on anticoagulation for a different indication. Some of them may not have had a CHADS-2 VASC score high enough. Some of them may have refused. Back then, I don't know that people were as readily going to the Watchman left atrial appendage occluder as they are now. But something we're certainly seeing more nowadays is patients that are going to open heart surgery for CABG almost exclusively are coming back with a left atrial appendage excision as part of that procedure, which fortunately negates in most patients, negates the need for long-term anticoagulation, even if they would later go into atrial fibrillation. So now, how did our data stack up to other data that was in the literature at the time, even though we weren't exactly looking at the same subset of patients as some of these other bigger randomized trials? So TRENDS and ASSERT were trials that looked at patients with pacemakers and defibrillators in place to see if they ended up developing AFib afterwards. 45% of patients, really a staggering number in the TRENDS trial, showed new AFib at 1.4 years. In ASSERT, 35% at 2.5 years had new AFib, and that was demonstrated to have an increased thromboembolic risk, as we intuitively would think. EMBRACE was a trial that looked at cryptogenic stroke, so patients post-stroke without previously known AFib who were suspected to have occult AFib. 16.1% were found to have new AFib on just 30-day monitoring. Similar numbers in the Crystal AF, which was implanted loop recorders. So not to beat a dead horse there, but asymptomatic AFib, very high prevalence in this population. So our study at 3.4%, while less than Crystal AF and the cryptogenic stroke population, was a clinically significant number for people that otherwise wouldn't have had AFib known, and they certainly benefited from longer duration of monitoring. This slide here, going back to the ability of patient detection. So the thing that I think changed for me clinically after learning about the breakdown of 40% of patients being completely asymptomatic with their AFib, and the next 44% of having some combination of manual and automatically detected events, having their over half of their events not being associated with AFib or even other arrhythmias a lot of times. What really changed for me was going away from the old thinking when I would see somebody in the emergency room or admitted to the inpatient ward, or someone transferred to the ICU. I no longer believe that the first time we catch AFib is the first time they actually had AFib. I see it quite often where a patient comes in and people are relying on their lack of symptoms in the time before 48 hours as evidence that they just went into AFib, and it's okay to cardiovert. It's okay to start an antiarrhythmic like an amiodarone drip. Again, I never assume that this is the first time we're catching that. So basically, these people come in, even if they say, yes, I know my palpitation started here or there, a lot of times people aren't really becoming clinically aware until they're starting to go into heart failure and things like that. So if we're cardioverting or starting antiarrhythmic drugs before we clear the left atrial appendage with a TEE, or nowadays we're using CTA a little bit more as well, then we're really putting ourselves at risk from a liability standpoint. We're putting the patients at a stroke risk. The picture here on the right just shows a sample of the cardiomobile device, which is an at-home device some of you may be familiar with. very cheap, usually 80 to 100 bucks, available at a lot of pharmacies, Walmart, Amazon. Allows the patients to accurately check their heart rhythm at home, get a nice quality 6-lead EKG that they can even send directly from their smartphone into our office. This is helpful for patients who we've got in our situation. We've got a lot of Amish patients who are self-pay and very cost conscious. They don't want to pay to have an implanted loop recorder put in or things like that. But this is a way that they can accurately check their rhythm at home. This is particularly helpful in patients who are resistant to anticoagulation for one reason or another. They may think that, well, I don't have that much AFib. It was just one time, or they know that their CHADS 2 VASC score is low. This can be a way to show them, look, you are having it more than you think. I've got one patient who her CHADS 2 VASC is low, but otherwise would warrant anticoagulation, but she doesn't want to be on blood thinners because she's of childbearing age and knows the risks of blood thinning there. So she gets up every morning and checks this and accurately charts her AFib or lack thereof. Another take-home point here, which is a little bit separate, is from the data, it is very clear that your stroke risk obviously does not go away once we restore sinus rhythm, that we can't simply take patients off because they haven't been in AFib in a while. There's data that up to 11 months, this was looking at patients with implanted pacemakers, defibrillators. Patients had stroke with AFib up to 11 months from their last time of AFib. So kind of this previous thinking that stroke happens when people are in AFib, they have a clot in the left atrial appendage, and then they restore sinus rhythm and get that restarted left atrial kick, and that sending the clot. That's really not the way we think about the stroke risk from AFib. We just now think of stroke risk as an independent, AFib being an independent stroke risk by itself, regardless of last time of AFib. AFib burden, however, is strongly correlated with your degree of stroke risk, and that's why we separated these numbers of AFib burden into episodes lasting 6 minutes or greater and episodes lasting 6 hours or longer. The ASSERT trial showed that just 6 minutes of AFib a day increased your stroke risk, and 6 hours a day doubling your stroke risk. That was heavily demonstrated in the TRENDS trial. So now backing away from the data and saying, okay, anecdotally, what is my style of practice? So when I'm ordering a heart monitor, how often am I doing it? And I like to break it down by what is my clinical indication. Sinus node dysfunction, which is an umbrella term that encompasses multiple different things, but we can think about one, inappropriate sinus tachycardia being part of that. Usually that's something where 7 days will be just fine. That's typically a younger, healthier person that we're worried about that in. But if it's the other type of sinus node dysfunction where an older person may have resting bradycardia, and I'm really concerned about chronotropic incompetence, whether or not it's just exertional dyspnea or maybe there's been some syncope or presyncope, I'm certainly going to err on the side of longer monitoring with 14, but likely 30 days. AV block, usually on the longer side as well. This is someone who maybe on the resting EKG, they've got a right bundle, left anterior fascicular block, and they had a syncopal episode in the recent past, and I've got a high index of suspicion for complete heart block or something like that. I'm certainly going to monitor them for longer, often 30 days, because that has pretty big implications if we're missing that, and they would certainly need expedited pacemaker implantation. AFib detection, I think we beat that horse. Longer is better. Now, if I'm just assessing AFib rate control, oftentimes 72 hours to 7 days. This is usually someone who is older, not particularly active. Maybe this is someone who is going to a nursing home, and I just want to make sure I'm not discharging them to be running 120, 140 beats a minute indefinitely. So that's something where a shorter duration is just fine. Although this may be a population who we have to worry about what we call tachybrady syndrome, and where they go fast when they're in atrial fibrillation. So we put them on beta blockers or calcium channel blockers. But then when they may paroxysmal go back into sinus rhythm, they may have a sinus conversion pause, or they may be bradycardic, then in which case we have to scale back their medication, and often they ping pong back and forth. We may need to talk about things like ablation with a pacemaker, so a pace and ablate or a AV node ablation type thing where they would be permanently pacemaker dependent, or whether we just need a pacemaker so that we can adequately put them on rate control medications. That would be reasons why, again, longer would be better. Consider going even up to 30 days for that. For syncope and palpitations, if this is a young person, they may have a squirrely story behind their syncope story where I'm not truly suspicious that it's cardiac. Their EKG is completely normal. Their exam's benign. Maybe I'll go 7 days, occasionally 14 days. But again, that same person for syncope or palpitations who has those older age and other evidence of conduction disease, I'm certainly going to go longer. Assessing PVC burden is the last one I'll talk about, where I'm often going shorter for that because that's something that doesn't really change much on a day-to-day basis. So 72 hours to 7 days, I think, would be completely reasonable there. So when I'm interpreting a heart monitor, this is kind of the template that I use to deliver the data to you guys, and hopefully it's done in a way that's readily interpretable and helpful to you. I always report minimum and maximum heart rate, average rate, was there a predominant rhythm sinus or not. The thing I would focus on here is that maximum sinus rate. I always emphasize sinus rate, because if you're getting a report that's just auto-generated by a computer, it's going to report the maximum rate that it sees. So sometimes I'll look and it otherwise would have reported a maximum rate of 200 beats a minute, when in reality the maximum sinus rate may have only been 120, but Grandpa had 3 beats of SVT at a rate of 200, and so it can be a little bit misleading there in terms of if you're having sinus node dysfunction or not. I always comment on the presence of PACs, the burden, PACs and PVCs, and then whether or not there is anything sustained in the form of SVT, NSVT, or VT. And then if there's other concerning things, AFib, sinus node dysfunction, high-grade AV block, or if there was mainly detected events there and what that correlated with both symptom-wise and what the rhythm showed. So now my treatment algorithm, what do I do with the data that I report back? So for that sinus rhythm, sinus node dysfunction, this is something where I care about, one, are they symptomatic? If they're not symptomatic, then usually this is not something that we concern ourselves with. Are they only bradycardic during sleep and they're fine when they're awake? Often we leave that alone. But primarily the biggest question, besides if the patient is symptomatic or not, is what happens when they exert themselves. We say, can they augment their heart rate? So if I'm in the office or if I'm seeing a consult in the hospital, the first thing I'll do is have the patient get up and walk down the hallway. Fortunately, with telemetry, we can see what their heart rate's doing. And I don't care if they're resting heart rates in the 40s if they get up where they need to be with exertion. Sometimes there's offending medications that we can stop and then consider repeating a monitor and hopefully avoid a pacemaker. But sometimes we need to just go ahead and refer them on to EP, where they can decide if this person's ready for a pacemaker, or whether something like a loop recorder can monitor them for 2 years and make sure we're not seeing signs of progressions. Oftentimes the determining factor may be we need to put this patient on the treadmill and put them through the Bruce protocol like a normal treadmill stress test and see if they're really able to get their heart rate up or not. Inappropriate sinus tachycardia. I'm not sure how much you guys are seeing this on a daily basis. I get asked this question a lot. I think these are predominantly younger patients. I see a lot more female than male. They're otherwise healthy. Keep in mind that the maximum sinus rate we know is 220 minus our age. So these young patients, they can get their heart rate up to 180 or so, or 190 with exertion and not be necessarily pathologic. To meet the definition of inappropriate sinus tachycardia, that rate, it should drop at night while they sleep, and then like clockwork every morning they get up and that heart rate gets up and it stays 100, 120 consistently throughout the day, drops at night, and it's rinse and repeat. So again, that's kind of why I really only need about 7 days to see that pattern. It should be chronic. There should not be paroxysmal with good days and bad days. If the patient's not symptomatic, we almost never have to do much of anything. A lot of my time is spent focusing on making sure that the where there's nothing iatrogenic that we're doing to the patient or nothing that they're doing to themselves that could be causing this tachycardia. Ultimately, occasionally we will start some form of AV nodal blockade and then rarely consider ivabradine or Corlinor, but I don't think I've had to do that in the last 3.5 years. In terms of PACs and SVT, very rarely am I really having to treat unless they're terribly symptomatic. We can start medication just to reduce palpitations. The patients who have SVT that lasts so long that they're having to go into the ER to get adenosine and things like that, sure, we'll put on beta blockers often. If they're having recurrent episodes, very low threshold to have these people ablated by my EP colleagues. It's a very safe, relatively quick, very effective ablation that can probably have a greater than 90% cure rate. PVC is a little bit more interesting from my standpoint. We all have PVCs, less than 1% is normal. 1 to 10% is a bit of a gray area. If I'm seeing 5 to 10%, especially with a patient that may have risk factors, I'm often ruling out ischemia. Structural evaluation, a simple echocardiogram is reasonable. Once we get above 10%, though, that's really where our ears start to perk up. After 10%, we can have what's considered a PVC-induced cardiomyopathy. Doesn't happen every time, but we certainly do see this. At that point, certainly ruling out ischemia, definitely treating with beta blockade, potentially need for antiarrhythmics. Beyond an echocardiogram, these are people that were really frequently going to cardiac MRI. Cardiac MRI is great, not just for giving us accurate LV function assessment, good valve assessments, but we're picking up lots of LGE, late gadolinium enhancement, fancy word for scar in the myocardium. We know that scar tissue is terrible in terms of conduction and being a nidus for arrhythmia and PVCs and things like that. And we're having an increasing awareness and diagnosis of infiltrative cardiomyopathies that may be causing this, things like amyloidosis, sarcoidosis. Certainly very concerned if we're seeing polymorphic VT or sustained VT as well. For AFib detection, yes, I care about time in AFib and AFib burden to determine anticoagulation, need for rhythm control. I care a lot about what is their percent time in RVR if I need to do a better job with rate control or not. And we've already talked about the importance of tachybrady syndrome and the possible need for pacemaker implantation and possible ablation for that as well. That about covers it. In the interest of time, I'm going to go ahead and conclude there and leave some time for questions. All right, well, thank you everybody for your time and attention. Feel free to reach out by phone or email if I can help anybody.